So ESCS, epileptic status epilepticus, and slow wave sleep. We're going to call it ESCS for the rest of the time because the full way is too hard to say. And by the end, we're going to invent a new name for it because it's not a great name. We'll talk about why. Okay, so we have some objectives. We are going to review briefly the difference between epileptic and developmental encephalopathy. Most of the names I'm seeing on this talk were here for last talk as well, so we're going to try to not repeat ourselves too much. We're going to define ESCS. We're going to discuss the relationship between or among ESCS, epilepsy, and encephalopathy. We're going to compare potential treatments for ESCS and identify next steps in ESCS research and some opportunities. So just briefly, encephalopathy is what we're still going to talk about because ESCS can lead to an epileptic encephalopathy, and that's in the end what we're treating more than an EEG pattern. So an encephalopathy, any diffuse disease of the brain that alters brain function, may impact memory, cognition, learning, personality, behavior, ability, may be global or more focused depending on underlying cause. Reversible versus irreversible, we're going to talk about the kind that is at least partially reversible. And static versus progressive, does it stay the same or does it get worse over time? Epileptic encephalopathy is the category of things that under which ESCS falls. It is where the epileptic activity itself contributes to the cognitive and behavioral impacts above and beyond what might be expected from the underlying pathology alone. The global or selective impairments may worsen or fluctuate over time, may be seen at any age along a spectrum of severity and across all epilepsies, and is potentially modifiable if we can treat it early and completely. I'll just highlight that bit about across all epilepsies. Any epilepsy can manifest as an epileptic encephalopathy from ESCS or other things. Some are more commonly associated with epileptic encephalopathy than others. And then we'll define developmental encephalopathy one more time from the last hour. Seizure and developmental impairment occur together and are epiphenomena of the underlying cause. So this is typically something that's genetic, and as a result of this underlying issue, we have seizures from an epilepsy, we have developmental issues, but the seizures and the developmental issues don't impact each other as much as in an epileptic encephalopathy. So the cognitive behavioral impact is due to the underlying cause, not the epilepsy. Therefore, typically not modifiable with seizure treatment and typically not reversible. It's important to recognize to avoid over treatment. So an example would be Rett syndrome is typically thought of as more of a developmental encephalopathy. Even if we do control seizures, we don't always see a huge developmental impact. And that's in contrast with some of our other epilepsy syndromes. So some conceptualize this as a continuum of encephalopathy where you have epileptic on one side and developmental on the other side of an area, and patients fall somewhere on this spectrum. I favor, again, thinking about it discretely, where we may have a component of epileptic, we may have a component of developmental. This is the one, the epileptic, that we want to address and modify, and we can address that at least partially independently of the developmental portion. The challenge is finding what it is epileptic encephalopathy and modifiable versus the developmental. So defining ESCS, or electrographic status epilepticus in sleep, is challenging because a lot of different people come at it differently. One thing that most agree on is that it has to do with a marker of ESCS is the epileptiform abnormalities getting much more frequent during slow wave sleep. and it being associated with some sort of cognitive cost over time. So just a very brief history of this process. So Landau-Kleffner syndrome was the first epileptic encephalopathy thought due to excess epileptiform activity, or the sparks, that was described, and that was described way back in 1957. At the time, when continuous EEG was unheard of, this was the authors actually talked about spikes during wakefulness. Way over here now in 1977, we started talking about the burden of epileptiform abnormalities during sleep, causing cognitive and developmental issues. And unlike Landau-Kleffner, which was primarily language regression, this cohort had other things going on as well. And then in 1989, the International League Against Epilepsy recognizes Landau-Kleffner syndrome and ESCS as discrete epileptic syndromes. So that's here, and there wasn't a lot written up until that point. And then from there on, we've seen more and more papers every year. So every bar represents a year between 1957 and 1921. So we're still learning a lot and discovering a lot about ESCS. So it's defined currently largely based on expert opinion. And if you get a bunch of experts together, they may or may not disagree, may or may not agree on things. And indeed, recently, 5 of the sort of top experts in ESCS got together, Doctors Hirsch, Caraballo, Dalla Bernardina, Lodenkemper, and Zuberi, and sat down and answered 5 questions about what they thought about ESCS. And the 5 of them, although very well versed in the subject and have contributed immensely to the literature, had different ideas. And so what it is, that the opinion ranges from a discrete syndrome, a thing that has definite features and it either is or isn't ESCS, versus an EEG pattern that may be associated with developmental challenges. The importance of the encephalopathy bit came through in everyone's opinion, though. In other words, you have to have a developmental impact, and finding that developmental impact is important. There is a lot of variability in EEG criteria. In general, the discharges, the abnormalities, have to activate during sleep. They have to get much more frequent during sleep. And by how much and how much, kind of what were the burden of the discharges during sleep, there's some disagreement about that. Some argue greater than 85%. Some are willing to accept less. A lot of papers these days use 50% of slow wave sleep being involved or greater. So what would it look like if we conceptualized ESCS as a syndrome? So the International League Against Epilepsy sat down a few years ago now and came up with this schema where kind of how we think about epilepsies. Patients present with different seizure types. Those seizure types make up different types of epilepsies, and a certain epilepsy may have multiple seizure types. Some of those epilepsies, when combined with other features of the clinical presentation, fit into epilepsy syndromes, things like West syndrome or Oda-Hara syndrome. The underlying cause of which, or the etiology of which, may be different things. And so a classical example would be infantile spasms as a part of West syndrome, which are infantile spasms, the hypsarrhythmia pattern, the chaotic pattern on EEG, and developmental regression all fit together and look similar. They fit into a clinical syndrome, but infantile spasms can be caused by multiple different things. They can be caused by underlying genetics. It can be caused by a metabolic issue, a structural brain issue like a brain malformation, or unknown, what we call idiopathic. And so if we conceptualize ESCS or Landau-Kleffner syndrome, or some people call it Penelope syndrome, as an epilepsy syndrome, it means the patients present in a cohesive way and have a lot in common. And then we talk about that syndrome can be caused by several different things, some of which are listed over here, including polymicrogyria, thalamic infarcts, structural issues, GRIN2A microdeletions, so GRIN mutations are something that have been more and more influenced with the ESCS pattern. I like to think about it a little bit differently because I think you can have many different epilepsy types can be complicated by the ESCS pattern on the EEG and an epileptic encephalopathy from that ESCS pattern. So I think thinking about it as we have our large group of epilepsies, some of which are reliable and consistent and stereotypic enough to be grouped as a clinical syndrome. And then most can manifest as seizures. Many can be complicated by ESCS pattern on the EEG. And many can have some component of encephalopathy, either from the ESCS or from an untreated seizure burden or both. The value in recognizing this is that we don't exclude the potential for ESCS or epileptic encephalopathy in a patient who doesn't have a more common or characteristic underlying epilepsy syndrome. In other words, we should be looking for this in multiple different types of patients. So this slide was from my last talk, and this is how I think of ESCS. ESCS to me is an EEG pattern, which may be associated with an epileptic encephalopathy, and teasing that apart, finding that connection is the challenging part. So ESCS refers to an EEG pattern characterized by sleep potentiation or activation of the epileptiform discharges during slow wave sleep. So however frequent they are during wakefulness, they have to become more frequent in sleep, especially slow wave sleep, where we do a lot of our cognitive heavy lifting. They can be generalized or focal, and actually have a very good paper showing that whether or not it's a generalized or focal pattern, the cognitive impact can be similar. The measurement's tricky. It's most commonly measured as spike wave index, or the percentage of slow wave sleep that is interrupted by epileptiform discharges. Originally described back in Landau-Kleffner's time as greater than 85%. Now more commonly in research papers is greater than 50%. And spike wave indices as little as 25% have been shown to correlate with cognitive decline in certain situations. So Michelle Van Hertem-Doss is the first author on a paper when she was at UCLA. And there was a case series. One of the patients had ESCS exacerbated by being on a certain seizure medication, had a spike wave index of 25%, but got better when taken off that medication, and the spike wave index decreased. So this is what we mean when we talk about ESCS. So during wakefulness, our patients do have typically some epileptiform discharge, some spark, some fingerprint of the underlying epilepsy that demonstrate that we're at an increased risk of having seizure. As we fall asleep, these get more frequent, but when we are in deep sleep, they dominate the EEG. This is a schematic representation of the spike wave index, or how much, what's the overall burden of those abnormalities, floating below 10% during wakefulness. And then as we get drowsy, we rise sharply. And then this sort of ebb and flow happens between non-REM, non-rapid eye movement, sleep being higher, and rapid eye movement, sleep typically being lower. And you see this pattern holds for patients when average. So this is an average of 10 patients in the study. This pattern of seeing a higher spike wave burden at the beginning of night as opposed to the end is something we commonly see, not always. So when I calculated overall spike wave index and report it out, and I'm using that as to guide therapy, I'm always making sure that I'm sampling throughout the night so I get a representation of the whole night. That incidentally is why I don't love just doing a short EEG and catching a nap, for example, to get a real sense of what's going on, because I want a composite average of what's happening the whole night. So that's why you'll see us asking for that 24-hour EEG as opposed to just a nap study. This is another representation. So this is one of our EEGs here. During wakefulness, these sharp pointed structures are epileptiform discharges. So we have them in wakefulness, 1, 2, 3, 4 out of the 10 seconds displayed. But during sleep, again, we potentiate or we activate. So every second here has at least one of those pointy epileptiform discharges in there. And this is the pattern that can disrupt the otherwise important work that we all do during slow wave sleep. So when people talk about ESES, we have to differentiate between, are we talking about just the EEG pattern, or are we talking about the encephalopathy or the cognitive bit that comes with it? So attempts have been made to kind of further describe electroclinical syndromes that fall under this bigger umbrella. So Landau-Kleffner syndrome is largely language regression with the high spike wave burden on the EEG. CSWS is more of a global cognitive decline associated with the ESES pattern. Autistic regression is a little bit different. It's a patient with autism who loses skills, and that loss of skill can be associated with increased abnormal activity on the EEG. And atypical benign partial epilepsies. These are otherwise sort of common epilepsies that are outgrown in childhood, like what used to be called benign Rolandic epilepsy or benign occipital epilepsy. But those epilepsies occur on a spectrum, and some patients have more severe seizure burden and cognitive burden from those otherwise benign epilepsies. I think the key here is that these are some subdivisions of patients who have epileptic encephalopathy from ESES, but this is not all of the patients. And so, you know, as we're sort of fitting patients into these buckets, we have to remember that there are patients who don't fit perfectly into that story, but who may be affected. And in my opinion, clinical phenotyping is becoming less important than identifying the presence of the epileptic encephalopathy and the underlying cause. So we did a lot of work for a long time as clinicians coming up with these groups of patients that look a certain way and behave a certain way. And the idea is that you want to be able to say something about how to treat someone and how they'll do. You know, medicine still works on a population level. So when I'm looking at the research, this is a group of patients who behave a certain way when exposed to a certain medication. We are not at the individualized, you know, sort of precision medicine point yet. That is the next step for all of us. The more accurately we can describe the illness experience of the patient, the more meaningful what I have to say can be for that individual patient, even if I'm basing that information on population level data. In other words, if I say all kids with seizures do this, that is not helpful, because we know that there are so many different seizure types and there's so many epilepsy types. But if I say patients with a GRIN2A mutation and ESES do this, that's much more specific, and that can be very much more helpful. So as we get better at determining the underlying cause, the etiology of all of this, these groupings into clinical syndromes, I think, become less important. But again, the identifying the epileptic encephalopathy from the ESES, that's a critical part, because then that allows us to act. Some medications may exacerbate ESES. I put it there again, just because it's, you know, we always want to look holistically at what's going on. So classically, sodium channel blockers like oxcarbazepine, carbamazepine can exacerbate the ESCS pattern in certain epilepsies. And so we always want to make sure that we are, number one, doing no harm, and then number two, treating and making our patients better. So all of this is to say that there is not a straight line between what we see on the EEG and what we get out at the other end. A big part of understanding outcome is truly getting a quantitative assessment of what is going on cognitively. And we do that with neuropsychological testing of some sort. The challenge with neuropsychological testing is that, number one, we have not figured out how to clone Dr. Romaine yet. There are not enough people who do this. Number two, it is not often covered by insurance, at least not multiple times. We don't have a validated instrument, something that is easier to use than 2 half-days of neuropsych testing that we can use quick and dirty in the clinic that is ESCS specific. The differences in the functional baseline of our patients is significant, and as is their age range. And so an instrument that might work for some patients will not work for others. And so we need the ability to assess a broad variety of patients across the neurodevelopmental spectrum. And then there's a concept of recency bias. If I'm acting quickly with this and I'm making changes and I want to see the results of those changes every few months, and I'm administering the same test over and over again, there is the possibility that a patient will just remember the answers of the test. And they'll get better at it over time just because they've recently done it. And that may over-exaggerate the effect of our treatment. And meanwhile, we're still struggling in school and other things. So getting a real handle on on outcome is essential, and it's non-trivial. It's very difficult. It is much harder than this piece. And like last hour, we have impactful comorbidities, ADHD, autism spectrum, and others that can make the picture more complicated. And so if my patient has autism and a gene giving some developmental encephalopathy, but also ESES giving some epileptic encephalopathy, really trying to figure out how much of that is modifiable and how best to address all of those components is critical and difficult. So smaller evidence than the last hour, but I'll bring up again the work of Schumann and Irwin. These were studies in the late 80s that demonstrated with careful testing that even individual epileptiform spikes can disrupt transiently underlying cognitive function, and that the location of those spikes has something to do with the underlying brain area that subserves that function. So spikes in the occipital cortex, which is visual cortex, can transiently obscure or disrupt visual processing, for example. And so we know that spikes can cause disruption, typically because they occur on the millisecond time frame, or at least the sub-second time frame. We're not seeing the effect of individual spikes in life. But when they stack up and they're very frequent, and then when they disrupt critical cognitive processes, then we start to see their effect. So there has been a lot of research on what happens during sleep. We all know we need it, and we know we are not as cognitively strong without it. And if we go several days without sleep, we really start to lose cognitive processing speed. So conversely, sleep is very important for the normal cognitive processes of life, memory consolidation, learning, kind of taking everything you learned during the day that's kind of floating around in this short and intermediate memory and uploading it to the cloud for the lack of a better term. So this is one paper, there's been many, but this one demonstrated that if we put enough EEG electrodes on the head and we record fast enough, we can see these nice slow oscillations that we see on the EEG actually have directionality. They move across the surface of the brain and specificity, they go someplace. And the idea is that these waves may functionally connect different areas of the brain. So the example I use, and this is an oversimplification, but I think it's a good model, is when we recall something from our past, say you recall your grandmother's house, there are different aspects of that memory. And those aspects are stored all over the brain. So there's a network of neurons that get triggered whenever you recall a specific memory. So in this case, grandma's house, the way it smelled, entorhinal cortex, the way it looked, neuro-occipital cortex, the way it felt, supramotor cortex, and the lateral temporal lobe, all of this, boom, happens together. So to write that, we need a process that kind of grabs and entangles these areas together. And it's thought that these oscillations during slow wave sleep lay down avenues, lay down networks across which this information can be stored in long term. And so the frequent spikes of ESES disrupt these long-term oscillations and thus disrupt the underlying cognitive processes without necessarily looking any different. So the child can look like they're sleeping normally, but they don't get as much out of sleep as they otherwise could. So what's at stake? So there have been a few studies that do this well. The challenge is, like we talked about, being able to do neuropsych testing repeatedly over time, having an instrument that makes sense, and doing it over a long enough period of time that is impactful, answers the question that we want. So this was a study in epilepsy. It looked at only 10 patients, but it looked long-term. So the average duration of follow-up was 22 years. So followed the patients for at least 22 years. All of the patients had ESCS, and all of the patients were treated to some degree. The patients with prolonged global regression had the worst outcome. So the biggest drop in skill, and the ones that had that persist longer than the others, had worse outcome 20 plus years later. In contrast, the patient with shorter and more specific deficits recovered better. And so the idea behind this paper is we want to treat ESCS sooner rather than later, and we'd like to treat it completely if possible. Another paper that demonstrated progressive intellectual impairment in children with ESCS. So this is a group of 22 children. They had ESCS for different reasons. So they were a heterogeneous group. This was only 2.5 years of follow-up on average. But even in those 2.5 years, there was decline in the majority of the cohort, and a third of them had greater than 12-point IQ loss, and that was independent of treatment. This study did not go into how well the patients were treated. The point of the study is that we have to be looking at cognition as an independent variable, because even if your seizures may be under control or getting better, we have to attend to development as well. Maybe the one outlier is this. This is a paper out of University of Michigan. The paper was actually looking at refractory generalized epilepsy, so a little different than ESCS, but it was comparing it to ESCS as a comparator group, and found that the overall IQs of the children with ESCS were actually higher than that of refractory generalized epilepsy and some other epilepsies as well. There were only 12 patients in this trial that had ESCS. And so, one wonders if the study didn't have, if it had more patients and more representative patients with ESCS, that we might see a larger effect. But Alternatively, this is a newer paper and maybe these patients are being treated more completely and having better outcomes. So what do we do for treatment once we've made the diagnosis? So again, the diagnosis is we see the EEG pattern consistent with ESES, and that is just an EEG pattern. So we activate during sleep, that it starts to become more frequent during sleep, and typically we say at least 50% of slow wave sleep being affected. What do we do about it? So we have options. We have options depend upon the underlying clinical scenario. So immunomodulatory therapy, especially cortical steroids, tends to be among the more effective treatment modalities. Benzodiazepines like diazepam and clobazam or Onfi are also used. We use a lot of seizure medications still, traditional seizure medications, and we use our spike suppressing seizure medications, the ones that tend to make the EEG better. Not all medications do. We're also avoiding the ones that can make this worse, principally our sodium channel blockers. There are other medications that aren't classic seizure medications, but can also work. These are like acetazolamide and amantadine. There's some evidence for ketogenic diet, surgery, and we have some research options on the horizon as well. So, cortical steroids are probably the most widely used non-traditional seizure medication for ESCS. And the reason is because among the options, they tend to score the best with regard to outcome. So most treatment regimens are oral. Oral steroids are absorbed just as well as IV. And most regimens occur, on a duration of 3 to 6 months. The trials have initial success rates that are between 77 and 81%, some of the bigger trials, but there's a significant relapse rate to most therapies with ESCS. So after relapse, you're talking just shy of 50% as a lasting treatment benefit, as measured by either reduction in spike wave index or development or both. Corticosteroids tend to perform better, and the effect appears to be longer lasting than conventional seizure medication. But again, that is dependent upon the patient and underlying seizure syndrome. Side effects can be significant with steroids, though, so we don't use them lightly. The side effects are typically reversible so long as we are using a relatively short course and we're not treating a patient who has underlying conditions that may be exacerbated by the steroids. But we do have to use them with some degree of caution. One paper that came out a few years ago from Minnesota looked at using pulsed dose steroids instead. So continuous steroids every day are typically the way we do it. Pulsed dose steroids are typically 1 or 2 doses a week. So on every Monday, we give a big pulse, and then the rest of the week, nothing. So that is not a typical regimen, but this paper demonstrated that 59% of their cohort experienced improvement in either language or behavior. There were no recorded serious side effects from the pulse dose steroids. And so I do use pulse dose steroids for some of our patients, depending on the clinical scenario. And that may be a way to prolong the effect of, the initial burst of steroids, and then to kind of decrease the relapse rate. You may be able to pulse after that to kind of keep the effect going. Intravenous immunoglobulin, or IVIG, is something that is talked about with ESCS, and it's another immunomodulatory agent. It is injected by IV. It's done in the hospital. It's been used as early as 1977 for refractory epilepsy and ESCS. That being said, there's still only a handful of individual cases reported in the literature. It's typically used really late in the clinical course when other things don't work. And so the results are as such. If you have a patient who's highly refractory, everything you try is, going to have a lower success chance of success because they failed so many things. Several patients in past series also received steroids after the IVIG again, so the data are clouded, but IVIG remains an option for highly refractory cases and have been reported to be successful. Benzodiazepines are the other kind of pillar of ESCS treatment. So you have the cortical steroids, mostly prednisone, prednisolone, oral, and then benzodiazepines used to be high dose Valium or diazepam. I did a lot of 1 milligram per kilogram challenge and then 0.5 milligram per kilogram sent home for X amount of time, 6 to 8 weeks. There are papers then pulsing that over time to maintain that. Otherwise, benzodiazepines have a high relapse rate. So we get that initial effect, but as soon as you're off the medication, you get the ESCS back again. More recently, clobazam or Onfi is supplanted some of the more traditional or what we call 1,4 benzodiazepines. And it seems to have, it's more likely that you would use Onfi as opposed to a Valium chronically. And so there's less of a chance for relapse because the patient stays on the medication for longer. The first randomized control trial is in progress for this, comparing corticosteroids with clobazam. It's a European cohort, and we do not have results from this yet. Traditional anti-seizure medications are still very much used, especially the ones that we call spike suppressing seizure medications, ones that can make the EEG better. We use them especially if there's an unmet seizure need. So if my patient is still having seizures and they have ESCS, then I use something that I can treat both simultaneously, get a 2-for-1. So Depakote, ethosuximide, saltiamine, I think is how you say that, is not available in the US, and so we do not use that. Acetazolamide is a similar compound. We use that more. Keppra or levetiracetam, probably on the rise and is more commonly used than some of the other ones. It is it's interesting because it has a very excellent safety profile. It's used in neonates, it's used in women with epilepsy who are pregnant. And so it's quite safe even at higher doses. And there are papers supporting its use. I find it very underlying cause or etiology specific. Some underlying causes respond well to levetiracetam or Keppra and some don't. Like I said, it would typically use when there are also comorbid undertreated seizures. And then again, third time, some anti-seizure medications may exacerbate the ESCS. So sometimes the first thing we do is take someone off a specific medication. So it is important to really have a handle on that. I will bring up Amantadine here. Amantadine is not a classical anti-seizure medication. It's a medication that targets the NMDA receptor and is used, among other things, as an antiviral medication. Because of its targeting of the NMDA receptor, it may have an outsized impact on ESCS or epileptic encephalopathy with ESCS associated with the GRIN mutations, GRIN, which is why we do more genetic testing with ESCS than we ever had before. It's typically pretty well tolerated. Upset stomach is the most common side effect. This is a cohort of 20 from UCLA, which is my alma mater. So I used a decent amount of amantadine there and continue to do so in my practice. Amantadine is also nice because it's been studied as an ADHD medication. So in my patients who have what I think is a component of epileptic encephalopathy from ESCS, and they also have attention deficit, I like to use this relatively early because it could be a twofer for me. So this graph here demonstrates that at baseline, the spike wave index in this patient's an average of 75. The first EEG after starting it, we had a drop in that average, although a pretty big spread, including EEG near normalizing. And then most recent EEG even better with some normalization in some patients. So this is a nice kind of less traditional, but can be very effective option. The ketogenic diet has limited evidence for ESCS, but it has been used. The largest cohort comes from Hopkins, Drs. Kelly and Kosov. Hopkins is probably still the biggest keto center. And this is a cohort from 2016 in which there were 38 children, 41% of which had greater than 50% seizure reduction, 45% with cognitive improvement, just over half with an EEG improvement, even though only 9% got their EEGs all the way to normal. Keto is typically well tolerated and is managed very well by our diet team, but it can be difficult for oral feeders who just want to eat what everyone else eats. And so we find ketogenic diet especially effective in patients who are formula dependent, either because of their age or because they have a gastric tube. Surgery can be a definitive option for ESES. So in patients who have a unilateral or one-sided lesion that is causing them refractory epilepsy, in patients who had that surgery for their epilepsy, the ESES often went away, even if we had discharges on both sides, and they had developmental improvement post-surgery. And so the message here is, if we have a lesion that may be amenable to surgery, we have to think about development as one of the outcomes. And so we're always talking about how many seizures are we having when there are seizures refractory. We also have to think about development. Is development getting worse? What will happen if this goes untreated? As one of the variables in our heads when we're thinking, is our patient a surgical candidate? Or in the case of families, when should we do the surgery? How quickly? Development plays an important role in that decision. And then there are multiple research trials. We are a part of one that I've listed here, which is a new pharmacologic agent, a new medication, a potential medication used in what they're calling in the trial epileptic encephalopathy with continuous spike and wave during sleep. This website here, the stillwaterprogram.com, about the program is a link to the study. And of course, we all know about it as well. We are enrolling now. And so this is a very promising potential therapy, and there are others on the horizon as well. So how do we organize this? And how do we make treatment decisions for our individual patients? This chart is an attempt at a kind of a schematic approach from this recent paper here. So it takes all patients with the ESES EEG pattern and says, do they have a structural etiology that is strictly on one side of their brain or not? If they do, we're thinking about epilepsy surgery early if it's warranted, if they're having refractory epilepsy and refractory seizures and other things. If there is no single one-sided structural etiology, they divide this into delay or arrest versus regression. And I think I would be more aggressive here in that I would move arrest over to the regression side. So if and it helps to talk about encephalopathy here, if our encephalopathy is static, which means we've always had the same amount of delay, versus if we have either stagnated recently, we had a developmental curve and that curve is starting to flatten out. So we're stagnating, what they mean by arrest here, or regression. If we're losing skills, I would be more aggressive in either one of those scenarios. Their aggressive scenario are steroids plus or minus clobazam. So this is the hormonal therapy plus benzodiazepine, as opposed to just when we're static doing the benzodiazepine alone. I think that's reasonable. They monitor for 3 months. I might tighten that up a little bit to 6 to 8 weeks, depending on the therapy. For steroids, I usually start the steroids, do 6 weeks, do another EEG, make sure we're tolerating it, and then give it 6 more weeks after that, as long as we're seeing things move in the right direction for that total 3 months, but I'm checking in between. If no improvement, then they jump to steroids here and they add clobazam here. I think I would, and then they go to third line, including ketogenic diet, IVIG. I would add our other seizure medications. I might pull amantadine further up just because its safety profile is so well tolerated, especially a comorbid attention deficit syndrome. But this is the kind of step-by-step algorithm that we follow when we're thinking about this. So the idea is we're getting our EEG, we're getting some sort of developmental assessment, we're making a change, we're already thinking about the next step. So we kind of always know it's coming if we need it. Because I anticipate that it will be asked, Epidiolex or the FDA approved CBD extract is being studied with ESES. Anecdotally, I have not seen either artisanal CBD or Epidiolex be a very effective spike suppressor. But I would love to see a randomized clinical trial kind of bearing that out one way or the other. So hopefully we will get those data from studies like this. So big take-home points. There are really no consensus guidelines around the diagnosis and management of ESCS. There's still, even if you get the top 5 minds together in one room, there is significant difference in the way they think about this. And that is because we don't have a ton of prospective randomized data for this yet. So research is critical. While identifying the EEG pattern is important, we definitely have to have the EEG pattern to call ESCS. Establishing the potential associated encephalopathy is absolutely critical. So what am I seeing developmentally that is associated with this EEG pattern? Because that determines how aggressively we treat and what we do about it. Treating the encephalopathy with ESCS early and completely is important for maximizing developmental outcome. Remember, we had that paper showing that the ESCS that was treated most quickly had the best developmental outcome. The ones that languished had worse developmental outcome even 20 years later. Aggressive therapy, including surgery, may be warranted in some cases. So if we have a structural focus and it is amenable to surgery, we are thinking very heavily about development as well as seizure burden when we're making that decision. And again, more research is needed. We could also use a better name. So ESCS as it stands now is epileptic status epilepticus in sleep. I think the name needs encephalopathy in there. It needs something to talk about development because that's what's important. So I would propose maybe changing that first E to encephalopathy with status epilepticus in sleep. And if we wanted to be really pedantic about it, it's not actually status epilepticus. That implies an actual seizure. So maybe encephalopathy with spike wave activation in sleep. And if we all get on the same page with what to call it, maybe the next step is how to treat it. And so with that, I will stop talking and stop sharing my screen and address any questions. And you can either just unmute and ask, or you can put it in the chat. It is your choice.
I have a question.
Yeah.
It's my grandson, and he wakes up every night, and he's videotaped constantly, and he's not visibly having a seizure, but he's up almost every night for several hours, and then will fall back to sleep. And he just started school, so then he's off to school. So, but he's not showing his seizures are mild. And they happen within 2 to 3 hours after he falls asleep. That's the only time he's ever had a seizure in 3 years. So what does that say?
It's a good question. So in general, and just a reminder that we can't talk about any specific patient because we don't know all the information. But in general, the sleep quality is important. We know that fragmented sleep, so frequent arousals at night or not getting enough sleep at night, up for hours at a time at night, can lower our seizure threshold, make seizures more likely in people who are susceptible to seizures. So we want good quality sleep with epilepsy. We also know all intuitively when we string together a few nights of bad sleep, we are not cognitively as sharp for a while. And so we really want to make sure that sleep is good quality. And so to look at reasons why we might be waking up at night and that sort of thing, some people do what's called a polysomnogram or a sleep study.
He's had,
Okay. And
So
so,
no-
that is good. That means that we don't have a sleep-related breathing disorder. We don't have excessive movement during sleep, like periodic limb movement disorder. And then the overnight EEG would be what would comment on any subclinical seizures, things that we're not seeing, or subtle clinical seizures that may be manifesting only as arousal, or the ESES pattern, this burden of epileptiform activity, the sparks, too many sparks during sleep. And so if we've had both of those, I think that, and we've excluded all of those possibilities, I would say that the arousals during the night may be from something else, but does not sound like it's from one of those things.
yeah, he's had all those and nothing has popped up. I don't think it's ESES, but I don't have all the information either. It's my grandson, so
Sure.
thank you. Good
Yeah,
information.
my pleasure.
Hi, thanks for talking about this.
Yeah.
What are you seeing happen at puberty with EEGs? We've been told that there's a good chance it'll be more normal after puberty or during puberty. He's 9 now, my son. So I'm hoping that's true, but I don't know if that's still the common belief or if there's changes to that.
Yeah, great. I mean, it's a great question. The somewhat depends on the underlying cause. In general, ESCS seems to be kind of a self-limited syndrome, if we're thinking about it that way. In other words, it comes on in early childhood, and eventually we outgrow that pattern. But the idea is that if we're treating, we are intervening during this period of developmental susceptibility, because we know that these years, these early school years, for example, are critical to what we are for the rest of our lives. And so another way to kind of conceptualize that is if we took a completely neurotypical 5-year-old and put them in sensory deprivation for a year, they would come out of that and they would not be typical anymore, not because of any changes in their brain necessarily, but because of missed opportunity. And so another way to think about this ESCS is that if we're not encoding the information as efficiently as we otherwise could be, and therefore we're not learning at the same rate we otherwise would be, then that is a missed opportunity that may be difficult to make up for later, which may be at least a component of why patients who have incompletely treated ESCS are not cognitively as high functioning as they otherwise would be in the future. As far as outgrowing epilepsy in general, around puberty, it really depends on the underlying cause. So around puberty, we undergo this concept of neuronal pruning. Our brains structurally change. And so young kids have excessive neurons, or I won't call them excessive, I'll say more than we do. And during the pruning process, we actually lose neurons, but the connections of the ones that remain are connected more deeply, what we call those deep dendritic connections. And so you can kind of see this by the way we learn. Kids typically learn just by like sponges. They absorb, they just write new information. Adults don't. Adults typically are taking in new information, they're checking it against what they already know, and they're modifying their current understanding of something. So they are modifying those pre-existing connections. Kids are writing new connections wholesale. And so that pruning process can also change the seizure network. And in some patients, it changes it for the better and they outgrow their seizures. And in some patients, unfortunately, it facilitates further seizures and they don't. And so it really depends in those cases on the underlying cause of the epilepsy.
Yeah, we don't have any idea of cause. We haven't had any success with genetic testing or anything yet. And we've actually stopped treating ESES and we're just treating clinical seizures. Have you seen any success with VIMPAT with ESES?
Not really. I mean, I'll never say never, but VIMPAT is one of those sodium channel blockers that could potentially exacerbate the ESES pattern. And so we would at least consider its impact on that, whether or not we think it may be causing help or harm. But in general, it's not one of my go-tos for ESES because of that sodium channel story.
I didn't realize it was one of the ones that can exacerbate it. It's the only one that's ever given us seizure control.
And that is
yeah.
often a balance, right? Because we know that uncontrolled seizures are also bad for development. And so,
one more last thing. What about VNS with ESES?
yeah, so neuromodulation in general is probably where we're going in the future with at least some refractory ESES patients. There hasn't been a lot written yet about the use of VNS for ESES in general. But physiologically, it makes sense to try it because the whole point of VNS is that on and off cycling throughout the day is supposed to disrupt seizure networks over time. I think as neuromodulation becomes more specific and responsive, where we're actually targeting specific areas, then it's going to be better at things like ESES. We just talked about this in our epilepsy group last Friday during our conference. Anecdotally, we have seen in patients VNS help ESES. I personally have not ever implanted one for that purpose.
Well, hopefully I can find a study. My son has a VNS as well. So we can maybe look for a study to, see if that's made a difference and if we can help with that.
Absolutely.
Thank you so much.
My pleasure. Just looking at the chat here. So as far as one night of study, on or off medication, so one night of study is typically sufficient for ESES. We typically get enough information over that 24 hours. And because we're looking at EEG, one could technically use an inpatient or an outpatient or ambulatory study to accomplish that. I prefer inpatient because we can control the variables, but I follow some ESES patient with ambulatory EEG as well. Typically do not come off medications for ESES only because I'm looking for the specific effect of whatever I'm using on the EEG pattern. So if I remove those, I may see the ESES pattern come back again. There is some controversy with regard to sleep deprivation because often we sleep deprived the night before we come in for a VTM to provoke seizures, but we also know that the background may be more active in the setting of sleep deprivation. So my preference is to I try to get a day in the life of my patient's brain, what it's doing all the time. So I typically keep medications the same and typically ask not to sleep deprive before we come in. And then so whether or not surgery is an option related to the age and the possibility of outgrowing ESES, I think it really depends on the underlying cause. If there is something that is amenable to surgery, we still consider development sort of throughout the patient's life as a potential variable that may affect whether or not they're a surgical candidate. ESES is one part of that. Another part of that is that a structural lesion may have its own negative effect on cognition going forward. So consider a lesion in the temporal lobe and having it just doing its abnormal stuff day in and day out may cause progressive memory issues where verbal memory lives in the left temporal lobe over time. So when we're sitting in our surgical conference, we're always thinking about the cognitive impact of both surgery, but also of not doing it, and trying to come up with sort of our best recommendation. My thought is that we should be thinking about ESES as a component of that conversation. And then another family had a daughter, 17, who had ESES, tried almost all the treatments, and then after 2 years of keto, ESES stopped. So, yeah, I think the question there is the impact of the keto versus the impact of time, kind of outgrowing the pattern. But I'm glad it's gone. Have you seen ESES stop and start again? So I think, depending on age, if we're in our later teenage years and the ESES is gone and it's been gone for a couple of years, I don't often see it come back. If we're still in the thick of it, if we're 7 or 8 and we were able to get control with medication, I have seen it recur because we're still developmentally in that time. And there is something about the brain and the developmental state in those kind of adolescent, or those early childhood and adolescent years that seem to be sort of permissive for the ESES pattern. And I have papers on the role of the thalamus and sleep spindles and all of these things that kind of happen, that there's a lot of good science behind it, but that is another talk. Dr. Romaine, I don't want to put you on the spot. I was seeing you mute and unmute a little while ago. Did you want to say anything?
Oh, no, I think I'm up next. So just double checking microphone and all that stuff.
Excellent. Then I leave everyone in extremely good hands.
So you think.
All right, it's been a true pleasure, and I see several families in the audience, so I appreciate your time and attention, and yes, be well, everyone, and thank you for this opportunity.